Hello, everybody. This will be a talk on esophageal disorders, and particularly here we're going to focus on the medical esophageal disorders. I have another talk where I go over the sort of more surgical issues like esophageal perforations. So you can go over to my general surgery videos, and I do have that. It should be under esophageal perforations or disturbances. So you can watch that if you want to get more information about this, because there are some concepts like Boerhaave syndrome that I'm not going to go into in this particular talk, although I will allude to it. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions I can get to help offset the cost of these videos, and I thank all those of you who have already donated. All right, so really when we talk about esophageal disorders, the major symptom that we are talking about is dysphagia. Difficulty swallowing. That's what dysphagia is. Now, a lot of people think, well, dysphagia must be like dyspepsia, where it's pain when eating. Well, no, it's not pain. Dysphagia is just difficulty eating, difficulty swallowing. Now, sometimes dysphagia can be accompanied by pain, but dysphagia all by itself just means difficulty swallowing. Now, a lot of times patients will describe dysphagia as a pressure or the food gets stuck. And a lot of times they'll point to a specific location, and that's going to be important. So are they pointing to their chest? Are they pointing to their neck? You want to know. Now, dysphagia can present with odynophagia, and that is pain. So odynophagia is pain on swallowing, and that tends to point towards esophagitis, whereas all these other more mechanical causes are just dysphagia. They're not pain. It's very important to discern when we're talking about dysphagia as to whether this is solids alone or solids and liquids. When it's solids alone, that's likely a mechanical obstruction. So a tumor, a web, a stricture, mechanical, something blocking, something getting in the way. Whereas if it's solids and liquids, that suggests a motility issue, so neuromuscular. So we're talking here about things like achalasia, for instance. Now, you need to always be vigilant for alarm symptoms, and these are your GI alarm symptoms. You've got a patient coming in with GI complaints, and they're over 60 years of age, they're anemic, they have heme-positive stools, they've had symptoms that have lasted a long time, or they have any unintended weight loss. If any of those things are present, then you need to consider the possibility that what you're dealing with may in fact be cancer. Now, there are three diagnostic modalities that are most commonly used. There's the barium swallow, which is really, really good for seeing if there are any anatomic issues, webs and strictures and stuff like that. There's the EGD, which gives us the opportunity to directly visualize the esophagus, as well as get a biopsy, which we may do if we suspect malignancy. And then there's the esophageal manometry, and that's something that we do to really look at motility. So you're going to see that with esophageal spasm. You're going to see that with achalasia. So if a patient has difficulty swallowing both liquids and solids, then you may think about getting a manometry. All right, these are going to be what we're going to talk about here, and I'm just going to go over each of these briefly and give you a general idea of the symptoms, how we diagnose it, and what the management is. This is an overview. We'll come back to this in a little bit. Achalasia is disordered peristalsis. So it results in a disordered opening of the lower esophageal sphincter. All of the muscular movements of the esophagus should be coordinated to move that bolus of food down to the lower esophageal sphincter and then open that sphincter so it can get into the stomach. If that is disordered, then what you're likely going to end up with is achalasia. So the lower esophageal sphincter is not relaxing properly, and food is going to get stuck in the lower esophagus, which results in that sensation of dysphagia. Because this is a disorder of the lower esophageal sphincter, nothing is going to get down, and that includes liquids. So you're going to have difficulty swallowing food and liquids. And a lot of times these patients will regurgitate because you got all this food sitting at the bottom of your esophagus. And so they'll regurgitate, but it's not vomit. It's not acidic. It's just munched up food and water. So dysphagia to solids and liquids, they can have retrosternal pain from the pressure. They can certainly have weight loss because they're unable to eat as much. And they can get halitosis because they've got food sitting at the bottom of their esophagus. Now, you can make this diagnosis clinically, but technically you need to have a barium esophagram. And that will show the classic bird's beak. Now, if you've got a patient with achalasia and they've got alarm symptoms, then you need to go for an EGD because we're considering the possibility of cancer. Okay? Now, this is what you're going to see with achalasia. If you get an esophagram, notice the bird's beak sign here. Manometry is the most accurate test to establish the diagnosis of achalasia. You can often presume it based on the esophagram, but you need to do manometry to formally diagnose it. The treatment is endoscopic dilation, and that will typically be enough. However, if that's not enough, what you can then do is Botox injection, and that will basically paralyze the sphincter and kind of simulate a reflux. I mean, you're weakening the sphincter, and so it'll make it easier for food to go down. But of course, the side effect is going to be that you can get reflux because remember that sphincter needs to be shut in order to keep stomach contents from going back up into the esophagus. The last resort is surgical. It's called a Heller myotomy. All right, so we kind of went over all of this, but achalasia in a patient with alarm symptoms, what we then need to do is an EGD. We're going to skip over the manometry. Esophageal cancer. Now, there's two separate types of esophageal cancer, which you probably remember from step one. They have very similar presentations because the presentation is due to the blockage. Now, you can have other symptoms consistent with cancer, like anemia, and you can have weight loss, but that's going to be the same in both of these cancers. And these two cancers, as you probably know, are squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is associated with smokers and alcoholics. It tends to be the proximal esophagus, and adenocarcinoma is associated with untreated, long-standing reflux disease, and it arises from Barrett's esophagus, and it tends to be the distal third. Now, if you suspect cancer, which you should suspect when you've got a patient with a consistent history and with alarm symptoms, then you do an EGD with biopsy. And you have to do the EGD because you've got to get the biopsy. Now, to follow up, if you do have a diagnosis of esophageal cancer, then you need to stage. And so you're going to be getting things like a chest CT and maybe a PET scan. But the important thing is to get an endoscopic ultrasound. And that's going to help you with staging. So it's important to know that and that goes for any cancer, once you make a diagnosis of cancer, you need to stage. The treatment for esophageal cancer is typically palliative. Most of them are not amenable to surgery. However, if they are, then you can do surgical resection. In many cases, we will administer a chemotherapeutic drug to shrink the tumor down to make it easier to resect. And typically the drug that's used is 5-fluorouracil, but there are other agents. That is not germane for your exam. This is what cancer looks like. You can see here on the left, this is a normal esophagus. And then you can see these nasty looking tumors that are growing in the esophagus. A Zenker's diverticulum is a posterior outpouching of the esophagus through the pharyngeal constrictor muscles. This is basically like, you can almost think of this like a diverticulum it's called a diverticulum, but you can think of it as like diverticulosis, where you get this outpouching of mucosa. Now, the problem with this is that food can get into that diverticulum. And so as you get food stuck here in this diverticulum, it will begin to rot, and that results in halitosis. So these patients, when they point to their dysphagia, they're going to point to their neck. They're going to say, I regurgitate, and when they're telling you this, you're like, oh, pew, your breath reeks. So that's the typical appearance with Zenkers. What they regurgitate is going to be really stinky because it tends to be rotten. The symptoms, of course, dysphagia, regurgitation. Sometimes they're able to actually squeeze their neck and get the food out. They can manually express it. But the extreme halitosis is going to be the giveaway, and that's often given to you on exam. The best initial and most accurate test is a barium swallow. That's going to show you the diverticulum. And the treatment is a cricopharyngotomy. So this is kind of the anatomy here. And by the way, this here is your diverticulum. So it's very easy to diagnose on barium swallow. Schottky's ring is a ring. It's a circumferential ring. So it's circumferential. It involves the entire circumference of the esophagus. And it results, therefore, in a narrowing. The symptoms are dysphagia, and that's going to be sensed around the bottom of the sternum, which is where these tend to be. Schottky's rings tend to be distal esophagus. And so again, best initial and most accurate test is the esophagram, because we're talking about anatomic things here. So a nice esophagram is going to show you where the problem is at. The treatment here is dilation if necessary, and typically it becomes necessary once they start developing symptoms. Okay, so notice you have a ring here. It's on both sides. Now, what's the difference between a ring and a web? A ring is circumferential, whereas a web is not. So this here is a web. It's just on one side, whereas this here is a ring. It's all around the esophagus. Now, esophageal webs are non-circumferential, and commonly where you'll see this, at least on exams, is in the constellation of Plummer-Vinson syndrome. And Plummer-Vinson syndrome is esophageal webs plus iron deficiency. So if you have a patient with esophageal webs, it's worth it to get iron studies. Again here, dysphagia is the symptom. It's going to be solids, not liquids, because this is mechanical. And typically these, unlike the rings, are going to be higher up, so more in the neck, in the cervical area. Again, most accurate, best initial test is the barium swallow. It will show you. And the treatment here, very similar. Dilation, and if they do have an iron deficiency, supplement them. Here's the web. So notice this one here on the right, where the red arrow is pointing. It's just on one side. That's a web. Also notice that you're in the cervical region. That tends to be in that area. Diffuse esophageal spasm is a disorder of neural conduction that results in spasm of the esophagus. This hurts. Okay, now this is not odynophagia. This comes on randomly. It's not associated with swallowing. However, it can be triggered, but this can come on out of nowhere. And so for that reason, because they're getting chest pain out of nowhere, what do you think these people come in thinking they've got? They come in thinking they've got a heart attack. They're pointing to their chest. It hurts. And so what's the best initial thing to do? You got to rule out cardiac cause. So get EKG and enzymes. That comes back normal, then you can go ahead and start thinking GI problems. And so with a normal EKG, once you've ruled out cardiac problems, then manometry is going to be the most accurate test for diffuse esophageal spasm. Now, can you get a barium swallow? Yes, you can. However, only about 5% are going to have findings. So the finding that you do see is corkscrew esophagus, and this gets hit on exams quite a bit, but only about 5% of DES patients will show that finding. Most of the time, their barium swallow is going to be normal. The first line therapy here is nitrates and calcium channel blockers. This is the corkscrew esophagus. If you're lucky enough to see it, most of the time you have to do manometry. Esophagitis is an infection or an irritation of the esophagus. It's very rare in immunocompetent patients. The symptom is odynophagia. So it's one of those things that can cause some dysphagia, but this is more odynophagia. It hurts to swallow. History is going to be vital. You want to know if they've got an immunodeficiency. If a patient has HIV, they're at high risk for all sorts of different esophagitis. Now, candidal esophagitis can occur in normal people, not immunocompetent people. If they're on antibiotics, it does happen from time to time. So if you've got a patient with oral thrush and difficult pain with swallowing, then you can just jump right to treatment. You don't need to get an EGD. And we would treat that with fluconazole. However, if you've got an immunocompetent patient or any patient that's failed fluconazole, you should really then at that point consider an EGD with biopsy, because the biopsy will help tell you what it is you're dealing with. So some of the causes, as mentioned, Candida, herpes simplex, cytomegalovirus, and HIV directly. Those are causes in immunocompromised patients. So you need to know how to treat each of those things. And you should also know that if you have a patient that's coming to you and they have esophagitis and they fail to respond to fluconazole and you have to get an EGD, what do you think you need to be doing for these patients? HIV test. Okay, because normal people just don't get those sorts of infections. With non-immunocompromised patients, of course, they can get Candida. Oftentimes, they're on antibiotics. They can have a caustic ingestion. Typically, this is intentional. It's a suicide attempt. I've seen this before. It's really unfortunate. Eosinophilic esophagitis is commonly seen in patients with other allergic or atopic issues. So look for a history of asthma, history of dermatitis, of eczema. The treatment here is proton pump inhibitors and aerosolized steroids, budesonide typically. And then there's pill esophagitis. The place where you really think of this is with those bisphosphonate drugs given for osteoporosis. These patients, when they take these pills, they need to be upright for an extended period of time. Otherwise, the pill can get lodged in the esophagus. It's very caustic, and it can cause ulceration. So when this does happen, we give sucralfate, viscous lidocaine for the pain, and then, of course, patient education. Okay, we'll finish with the Mallory-Weiss tear. I think that's all we've got. Oh, no, we got one more thing. Okay, so the Mallory-Weiss tear is not a cause of dysphagia or odynophagia. This is a cause of painless hematemesis. So what you typically have here is a patient who goes on a night of binge drinking, wakes up the next morning, pukes their lungs out, and now starts puking up blood. That is typical of a Mallory-Weiss tear. These are not chronic alcoholics. They could be, but a lot of times they're frat boys. And, they just retch and they start puking up blood. That's a typical Mallory-Weiss tear. And a lot of times this can be diagnosed based on history. However, if you definitively need to diagnose this, you will need to do an EGD. But this is pretty self-limited. Now, where you want to separate this from is Boerhaave syndrome. Boerhaave syndrome is a complete rupture of the esophagus. You would expect to see crepitus or feel crepitus. You would want to get a chest x-ray at that point, an abdominal x-ray looking for subdiaphragmatic air, and ultimately you want to do an esophagram. But if you ever suspect an esophageal tear, you do not get a barium esophagram. You will get a gastrographin esophagram because it's less likely to cause irritation of the peritoneum. Now, finally, we've got systemic sclerosis with GERD. I'm not going to go into this too much here, but suffice it to say that CREST syndrome can cause dysphagia due to poor motility, and it can also cause GERD if it affects the lower esophageal sphincter. So this can manifest in a couple different ways, but you should be aware that dysmotility of the esophagus can be part of the CREST syndrome. This is just a recap of everything we talked about. So this is the most important stuff. You should know the symptoms, what makes each of these things unique, if anything, what we do to diagnose. Just know in general, if we're thinking of just dysphagia to solids, if we think it's mechanical, then we get a barium esophagram. But if we're really thinking that this is something that's a motility problem, then we're going to need to get manometry. If you ever have a patient who's got alarm symptoms, they're older, they're anemic, they've lost weight, anything that makes you think they could have a cancer going on, then you need to get an EGD, because that's the only way we can get a biopsy. Remember, with esophageal spasm, pain comes out of nowhere, it's in their chest, got to rule out cardiac causes. Even if you think it is, even if you think that it's esophageal spasm, you still need to rule out cardiac causes all the time. Okay, so that should be enough for you. I strongly recommend that you go over now and watch the surgery video that I did, because I go into a little bit kind of a different angle talking about some similar things.